contact in the chat, please take a minute to do that. As you noticed, we are recording today's session. We have it shared on our Canvas site as well as on our website. We use these for educational and quality improvement purposes. So if you don't wish to be recorded, take a minute and disconnect from the session. ECHO, again, if you've never joined an ECHO session, we are hoping that this is an interactive community, meaning that turn on your cameras, engage in the presentation, ask questions, reach out to your colleagues. This is a great way to learn from others and know what everybody is doing within this network. When we are talking about anybody or asking any questions, please remember to protect their individual privacy. So avoid using first and last names anywhere that we would be able to identify somebody or where they're from. We've all been on Zoom for quite a few years. So we probably all know how to rename our profiles, but if you do not, here is a page that tells you how to rename your profile. If you'll put where you're from or what your discipline is, it is a nice way to, once again, build that community of practice. There's a way to raise your hand if you ever have any questions. Please feel free to put them in chat, but also you can raise your hand and we'll call out on you. Pre-registering you can do that by reaching out to Early ECHO, and then also the case, the way that we send out for certificate of attendance is through those as well as the surveys. So take a minute and fill out those surveys that will get sent out at the end of the session. Canvas is our platform that we use to store information. If you have any struggles getting onto Canvas, please reach out to either Kurt Phillips or Early ECHO at usu.edu, and we'll see if we can help figure that out for you. Canvas also has what's called a discussion board. You can put questions on there for other participants to answer or to have hub members respond to some of those questions. Case studies are a great way to get information about families or real life situations that we're working on. It's a great way to hear additional recommendations, get new input or motivation from working with your cases. So if you're interested in doing that, reach out to us and we'll let you know how those case presentations go. REDCap is the survey that we use, the survey system. If you have not gotten a survey, always check your junk and spam email folders. We send those out either the day or the next day after the session and then consecutively after the session. So you will get emails about those. Please make sure to fill those out. That's how we keep these sessions free. And the reports that we turn into our grants. If you've not taken a minute, follow us on Instagram or Facebook. We share information about all of our ECHO sessions, information that we get from our presenters or any new information that we have. So I'm really excited today to have Denise Johnson share with us about vision and early childhood. She brings a wealth of information, so I'm going to stop sharing and turn that over to her to just take over.
Okay, thank you, Janelle. I don't know if I'm excited to be here. I am. I'm just, for some reason, I'm nervous, and I've done this for a long time. But just a little bit about my background. I'm Denise Johnson, and I live in Cache Valley, and I work with children in up to 3 program. I work for the School for the Deaf and Blind in the PIP BVI program. For those of you in Utah, you should hopefully be familiar with our program. Those of you out of the state, it's the PIP program is a parent-infant program, and we just do early intervention in homes with families with children who are blind or visually impaired. And I've been working there for about 13 years. I changed my career, I guess you could say, back 23 years ago, or maybe it's been just 20, when I had 2 children who have vision impairments. And so I have the background as a parent and then now a professional, so that I feel like that really helps me when I'm working in homes with families to have been on that side as well. So let's get started. Let me share my screen here. Just before I get going, I just want to say that any photos that I have on here that aren't, it doesn't have a link of where I got the photo from, are children that I have worked with who the parents have given me permission to share their pictures on here. So some of you may recognize them, but anyway. Okay, so what I want to go over today is we're going to talk briefly about these things. I can't go in too much depth with the time that we have. And also just a little disclaimer, I'm not an expert on every vision impairment. In fact, I just recently was found out one of the children I work with received a diagnosis that I have never heard of before. And so I learn as I go, excuse me. So, okay, we'll talk about the structure of the eye just briefly. Early vision development, what is typical, some red flags, things that might indicate that there's a vision impairment, common visual impairments in children. I'd like to spend a little bit of time with cortical vision impairment, and then when to refer a child for a vision evaluation and what qualifies a child for EI vision services. And if you have any questions as we go, you can put them into the chat and they can interrupt me and I can do my best to answer your questions, and we'll also have time at the end. Okay, this is just, I just want you to get an idea of what the anatomy of the eye. I have a little video right after this that's going to go into a little bit more depth, but some of the main parts to focus on are the lens here, the iris, and then this right here is the pupil, and then the cornea is the outer part, and then this yellow rim around here is the retina, and that's a pretty important part of vision. And then this here is the optic nerve that takes what the eye is seeing to the brain, and then the optic disc is right here. I know I did not give you very much information there, and hopefully this cheesy video that I have here will help. This video is not to make you feel like you don't know anything. It is a video for children, but I think that it's really quick. It wasn't too long, but it gives a nice overview of how the eye works.
Cornea. This is the layer that covers the front of the eye. And it acts like a camera lens. It focuses the light that is coming in through it, and with the lens, it makes sure that the image that reaches the back of the eye is in focus. Sclera. This is the tough white skin that covers the outside of the eyeball. Iris. It is the colored part of our eye that works like a camera shutter. It controls the amount of light that enters the eye. Pupil. This is the hole in the middle of the iris, and it lets light into our eye. The lens. The lens helps the cornea to focus light onto the retina. It gets thicker or thinner to make sure that the image on the retina is very clear. Whoa! Retina. Retina has 2 lots of cells called rods to see black and white, and cones to see the colors. They turn the picture into an electrical message for our brain. Optic nerve. The electrical message from the retina travels along the optic nerve to our brain. Eyelids. These protect our eyes. The eyelids can shut out light so that we can sleep. Wow! Eyelids blink so they can keep a moist film over the cornea. Eyelashes. Eyelashes catch the dirt and they trap it as our eyelids close. Eyebrows. Eyebrows also help to keep sweat and dirt out of our eyes. Now, let's see in a simple way how our eyes work. Our eye works in a similar way to a camera. Light from something we look at passes through the lens of our eye and is picked up by the retina on the back of our eye. Do you notice something weird? Yeah, the picture that our eye captures is upside down. Why don't we see things upside down? Well, our eye sends the picture to the visual processing part of our brain, and the brain turns that picture the right way up, so we see things the right way up.
Okay. Oops, I don't want to play the
Cornea.
Sorry about that. Okay, so just about the video, I know it's cheesy, but hopefully it just gave you a real quick overview of how the eye works and how important the different parts of the eye are in their the job that they do to help us see. There's a lot more we could go into with that, but I don't think that that is something that is necessary in this presentation. So this is a little overview of what early vision development looks like. So some of the things that we want to see in a child from birth to a month is that a baby will begin to follow slowly moving faces, lights, and objects. By about 2 to 3 months, they begin to notice their hands. They'll make eye contact with a parent or a caregiver, and they're able to see and return their parent's smile. So that's when we see that social smile start to come. By 3 and 4 months, the baby starts to reach for objects or to the parent or caregiver's face, and they will grasp onto objects and hold objects. By 5 months, the baby brings objects to their mouth. And by 6 and 7 months, they purposefully reach for objects. By 8 to 10 months, the baby recognizes the faces of family members and or caregivers and looks at small objects such as cereal or a raisin. And by 12 months, baby uses their index finger to point to pictures in a book or looks for an object dropped in a container. Now, one thing I like to point out when talking about these things is you'll notice that a lot of those things had to do with motor or fine motor, because vision really is tied to everything. You know, if they're not seeing objects, they're not going to know to even reach to get them. And but this is also can be a challenge with children who have multiple disabilities, where I might get a referral that they're not reaching to get things, and so that it could possibly be a vision thing. But then I go in and realize, no, it's more of a motor thing. It's not that they cannot see the object to reach and grasp it. They just don't have the muscles and that ability with their motor development to reach and get that. And we can talk more about that when we get to the when to refer. But vision can be tricky. It's just like anything else. If a child is born early, they're obviously not going to be reaching these milestones at the typical time. And so we need to take that into consideration. Often I'll get a referral for a child who's 0 months adjusted. And I can't really have too many high expectations of that child really following things yet, because they're early. We want to watch and see. I always, most often, will still qualify the child to watch and see how that vision develops, but we have to consider their age and other abilities and disabilities that they might have to see why they might not be doing these things. This is just a visual, I think it's kind of a fun way to look at vision development. It's kind of like a little game, and I sent this as a handout if anyone was interested in using this to share with families or just for their own benefit. It goes through some of the same things that we read about, that I just read over that slide, of things that children as babies are developing, the skills that they are getting. I like to point out, this one wasn't on there, that other one, but babies' eyes appear straight. You'll see that's by 5 months. So that's just showing that sometimes, around 3 months, if their eyes aren't working together, that could be it could be a normal thing. It could be just that the eyes are, they have some delayed visual maturation. Things are just starting to work together, but it's definitely something to keep an eye on if you see any of these milestones not being reached. Okay, some of the things that we like to look for that could be, let us know that there could be a problem are if a child is rubbing their eyes or blinks often, closes or covers one eye when looking at a close object, squinting when trying to see objects near or far away. One that I see often is tilting their head or turning their face so that they can see the object better, or trying to reach to see something near. When they're trying to reach to see something near or far away, they kind of turn their head. Bringing toys or books close to their face. They're not able to see something that other people can see. This could be a red flag. They avoid activities that require close-up vision, like reading or drawing, and they seem unusually clumsy, frequently bumping into things. Now, having read over all of these things, just because we see some of these red flags does not always necessarily mean that they have a vision impairment. You know, that they might just need a pair of glasses like I'm wearing, and some of you, just to help to fix some refractive error or whatever the case may be. But it could also indicate that there's something more going on. So it's always a good idea to make a referral or have a discussion with the family to take their child to the eye doctor, or, you know, to get it looked out, because it could be a problem. Some others, extreme light sensitivity. Instead of red eyes in a photo, there's always a white spot or white pupils. And you notice changes in the baby's eyes from how they usually look. If they start to look different, droopy eyelids, anything different, that would be a time that's a red flag. After 3 months of age, contact the pediatrician if you notice that the eyes don't follow or track an object moved from side to side of the child's face. Their eyes seem to jump or wiggle back and forth. Their eyes turn way in or out, and then they stay that way. Or they have a consistent head tilt when they look at things. These are all things that we'd want to have the doctor take a look at. In fact, yesterday I was on a home visit with a little one whose vision is actually progressing really well, and he probably doesn't really need my services, but you all know we can keep kids when they're cute, right? We don't have to like take them off our caseload. So that might be a reason why he's on mine. But anyway, his mom said, you know, I've noticed when he's sleepy or when I'm holding him and feeding him that one of his eyes is drifting. And so that could be a normal thing. It could not be a normal thing. So it's something that there's nothing that I can do to fix that. That's a doctor thing. We're going to talk about that later. But it's something to, you know, I told her to keep track of when that's happening and bring that up with the eye doctor at your next checkup and see. It could be an eye muscle thing. You know, there's a lot of things that it could be, but just having families keep an eye on things and document when they're happening is an important thing, so that we can see if there's a trend or if it's getting worse, or if it's just, see, my children have albinism, the ones that I have that have vision impairments, and they have nystagmus, which is that where the eyes wiggle back and forth. And when they're tired, it is like nonstop back and forth. So, but that's normal for them. So just kind of seeing what the doctor would say on what is normal. Okay, do I have any questions up to this point? Okay, I'm not a good waiter. Okay, if you didn't say anything, because I can't see everybody, I'm just gonna keep going. Okay, so some of the common visual impairments that we see, oops, sorry about that. Trying to move my pictures and I moved my slide, are refractive errors, strabismus, amblyopia, which is commonly called lazy eye, cortical vision impairment or CVI, retinopathy of prematurity is ROP, optic nerve hypoplasia. I didn't put, you know, we love acronyms here. That's also O and H. albinism, and then optic nerve atrophy, or ONA. These are just some of the more common visual impairments. We obviously see many other things too, but I just wanted to go through these really quickly so that you kind of have an idea of what each one of them are. Refractive errors are the type of vision that makes it hard for us to see clearly. It's very common. Most people who are wearing glasses have a refractive error. It happens when the shape of your eye keeps the light from focusing correctly on the retina. And so using glasses can help to correct that. Myopia is nearsightedness. That's when we can see things near clearly. Hyperopia is farsightedness, and this is when it's easier to see things far away clearly. Presbyopia, or loss of near vision with age, that would be why I'm wearing glasses. And then astigmatism is when the cornea or the lens have mismatched curves. And all of these are treated with glasses. So oftentimes, I might see a referral that says the child was diagnosed with astigmatism. And my immediate thing is, well, so go to get some glasses and treat. It can be treated with glasses. But sometimes when we see these big words, we think, oh no, that's a bad thing. So I'll often get referrals for some of these things. And a lot of refractive errors are not things that would necessarily qualify, or a child would not necessarily need vision services. But a lot of those behaviors that we saw in the red flags list could have to do with refractive errors and could very easily be treated. Strabismus is very common. Also, this is a misalignment of the eyes, where if an eye is turning in, that would be esotropia. If an eye is turning out, exotropia. And then this bottom one is when it goes up. The treatment for strabismus is oftentimes patching. They'll patch the good eye that will help to strengthen the muscles on the bad or the weaker eye. Sometimes they will put eye drops in the good eye that will kind of blur their vision. So that will make the bad eye have to work. And sometimes glasses will help to fix the problem. One of my children, she would have strabismus. One of her eyes would go in when her glasses were not on. So when her glasses were on, it helped to keep them working together. So it just depends on the situation. There is also, they can do surgery to treat a problem with the eye muscles. They usually watch it for a little bit and see how it's going to develop when they're tiny and see if it will get strengthened. But if not, they'll go in, and it sounds really scary for families when their child's going to have surgery on their eyes, but this is kind of like getting your tonsils out. It's a pretty routine, simple thing. They just go in and they either have to tighten that muscle on one of these, a situation with esotropia, and then exotropia, they kind of have to do some loosening in there to help to get these eyes to work together straight. Okay, amblyopia, or lazy eye. This is one of the most common eye disorders in children, when one or both eyes are impaired because the eye and the brain are not properly working together. So a lazy eye develops when the image in one eye is blurred and it's clear in the other. And so what will happen is the brain will turn off that. As the images are sent to the brain will turn off that blurred image and only focus on the clear one. And that's why they do vision screening in schools for children with the E, where they have to show which direction it's pointing, is to see if a child is developing lazy eye, because if it's not treated when they're young, the brain will just turn off that bad eye, and basically they won't be using that eye, that they'll be blind in that eye. So it's an important one to recognize and to get treated. Okay, cortical vision impairment is a neurological disorder that results in unique visual responses to people, educational materials, and the environment. When children with CVI see an ophthalmologist, they are told that there's nothing structurally wrong with the eyes. So I've had children go into that, I'll go to the, or I'll get a referral that they're not looking at things. They are looking past things. They don't make eye contact. And I'll say, we'll definitely say, well, let's go in and see an ophthalmologist. They take them in and the doctor says, oh, their eyes are just fine. They are not just fine. But that's because the problem lies in the pathways from the eyes to the brain through that optical nerve. And it's actually the pathways, not the optical nerve, that's damaged. So if there's been any trauma to the brain, then if I get a referral for a child that's had any type of trauma to the brain, whether it's they've gone without oxygen at birth, they have hydrocephalus, there's a number of them. I don't know why my mind is blank, but then I'll look at the referrals coming through, and if I see that on there, I'll think, okay, I need to keep an eye on this one because the child can definitely have CVI or problems processing what their eyes are seeing. Okay, we'll talk more about CVI later. Another one is ROP, or Retinopathy of Prematurity. And this is caused when small abnormal blood vessels form in the baby's eyes. So the vessels can lead to, as the vessels are formed, they lead to scarring and bleeding, and they can also cause the retina to move out of its position, and that is called retinal detachment. ROP is graded depending on the severity and how many or how far the vessels have grown. So I've had referrals of ROP that are ROP stage 1, and that's, I don't want to say that's awesome. That's not a real severe, but as it's ROP stage 4 or 5, that's a little bit more severe and something that we want to keep an eye on. And once the development of the blood vessels is complete, then the child is no longer has ROP. And a lot of times children who are premature will have had ROP that has been treated with laser therapies and things, and it's been resolved, which is awesome. Now, it wasn't so much before we had everything that we have now to help these little ones. Optic nerve hypoplasia refers to the underdevelopment of the optic nerve during pregnancy. It can affect only one eye, or it can affect both. And it's not genetic, and it's not progressive, and there is no cure. And there is like a spectrum, as is with all of these, and I'm sure all of you are very familiar. Just because one child has ONH doesn't mean the next child you work with is going to have the same challenges or present the same way. It can be very different. And okay, albinism is when there's an absent or reduced pigment in their eyes, skin, or hair. They have inherited genes that do not make the usual amounts of pigment called melanin, which is necessary for the full development of the retina. There's 2 different kinds of albinism. There's ocular albinism, which it just affects the eyes. And then there's oculocutaneous albinism, which affects the eyes, the skin, and the hair. And then the last one I think on the list that we'll talk about is ONA, optic nerve atrophy. And this is a permanent visual impairment caused by damage to the optic nerve. So the optic nerve functions like a cable carrying information from the eye to be processed by the brain. It's comprised of over 1 million small nerve fibers. And when some of these nerve fibers are damaged through disease, the brain doesn't receive the complete vision information and sight becomes blurred. Often I'll see on an eye report that the optic nerve is pale. I wish I could really see. I would love to really see it and have a doctor point things out to me. But apparently this picture is a healthy optic nerve because it's pinkish. You can see that it's more pink, and this one is pale. It's not as pink. Okay, any questions up to this point? I see that there have been things in the chat, but I haven't. Okay, never mind. It's not for me. Oops. Okay, so CVI is the leading cause of visual impairment in children, yet most people have never heard of it. And it's one of the vision impairments that is really hard to get diagnosed from an eye doctor. The National Institutes of Health website cites a CVI prevalence of 10.5% of all children with developmental disabilities. A congenital or acquired brain-based visual impairment with onset in childhood, unexplained by an ocular disorder and associated with unique visual and behavioral characteristics. And it is the leading cause of congenital blindness, which is blindness at birth in the US. These are some of the most common causes of CVI: perinatal hypoxia or hypoxic encephalopathy, or HIE, sometimes called infant stroke, prematurity, and hydrocephalus. There's other etiologies in children and adults. So if there's been any traumatic brain injury, stroke, any congenital anomalies, central nervous system infections, neonatal hypoglycemia, and seizures. Children who present with these conditions should be screened for CVI. So it's you can see where there's so many different causes or reasons why a child could have CVI that it is so common. In order for a child to be diagnosed with CVI, check my time, there needs to be three things. One, the child has to have a normal eye exam or go to the eye doctor and there's not a reason why the child is not using vision. The child has a medical history that includes neurological problems, and the child exhibits unique visual and behavioral characteristics. And there are 10, I think that's my next slide. Yep, there are 10 characteristics of CVI. I could do a whole presentation on CVI. So the first one is a color preference. We typically see that children, especially that are more severe, that the color red tends to be their color preference, that means that they will see that color. They might not see something that's got a lot of different colors or that's blue. They might. We always start with red, but sometimes we find that a child will really focus on and see the color yellow maybe. So it's just working through that and teaching families and different things that they can try to see if the child will, in a controlled environment with a plain background, if they will visually attend to a different color. The need for movement. I love to have slinkies that I take to families whose children have CVI, because it's just that simple movement of a slinky can draw that attention, and some children have to have movement for them to be able to visually attend to something. So when we do the Cvi range, which is the protocol that we use for CVI, we would indicate how much of a need for movement that child needs in order to be able to visually attend. Visual latency is that time, that period of waiting. If a child needs some time to wait before they will visually attend, then that would be another of the characteristics of CVI. Visual field preference. Maybe a lot of times children with CVI are only using their peripheral vision. Sometimes we'll see them use the central, maybe they don't use lower. So anyway, having a visual field preference is also a characteristic. Difficulty with visual complexity. This is huge. If there's just too much going on visually, when I go on home visits with a child with CVI, I try to wear just a plain color so that if I'm holding something that I want them to look at, they don't have too much to look through to see the item that I would like them to see. Often we use, just a plain black poster board that can help to eliminate any of the background clutter for them to be able to visually focus and engage. Light gazing and non-purposeful gaze. This is staring off at the windows, very common for children who have CVI, difficulty with distance viewing. Atypical visual reflexes, that is referring to like a defensive blink. if they don't have that defensive blink. I go to my nose because that's how I test it on kids. Or that touch. Difficulty with visual novelty, so seeing something that's new, that they might not visually attend to something that's new. So it needs to be something that they're familiar with. The same thing, I use a lot of pom-pom, a Mylar red pom-pom, that children, once they get used to that, to bring in something different, they might not, it might be like they can't even see anything because I've changed what it is that I want them to look at. So a lot of times at the beginning, we use the same things for the child to visually focus on. And then we might introduce, as they've developed those beginning visual skills, then we can start to introduce new objects to see if they will attend, maybe the same color, but just a different object. And then we can change the color. And there's a lot that we can do to play around with that. And then the last one is absence of visual guided reach. So these characteristics were all developed by Dr. Christine Roman Lansey. She has created the Cvi Range, which is what we use as a functional vision assessment for children who have CVI or who have suspected CVI. Most of the time, children that I'm working with, I'll go in and based on those the three qualifications for CVI, which I'll go back, where they have a normal eye exam, they've had some type of neurological history problem, and then they have any of these 10 characteristics. I would qualify a child based on my clinical opinion that they have suspected CVI. Of course, I'm not diagnosing them with CVI. I've been accused of doing that before, but I would like to be in there to be able to help with these behaviors and to support families as they go to ophthalmologists to have them really look and to be able to get that diagnosis. This is just what these things, let's see what time it is, I've got to hurry, what these different characteristics would look like and as we implement strategies and lessons if they're in school. So what color are we choosing for materials? How much movement or reflective properties are required? How long do we need to present materials for the child to visually engage? Where do we present the materials? If they're using their peripheral vision and we're presenting it in their central, they're not going to visually respond. So we want to make sure we're presenting it to to the visual field that they prefer. Which level of complexity do we present with? Does it need to be totally controlled? Can there be a little bit of busyness? Is the environment contained with, or does the environment need to have controlled lighting? So not where they can look towards the light, it's more dim and not dim that they can't use it, or maybe we have to shine a flashlight on the item that we want the child to look at. How close to the face do you present materials for distance viewing? And then visual novelty, how do the materials relate to items already committed to visual memory? So things that they're already familiar with, then how do we introduce new things that they've already committed to their visual memory, and now they can start to look at something new. And then how many cues, prompts, or how much time does a student need to respond to touch and take question, like to how many prompts do they need to, if you're touching their elbow, to help them to reach in and grasp that object. Okay. So we here in Utah at USW, we have started doing the NAVEG, which is a neonatal assessment visual European grid that was created in, you know what, now I can't even remember what country, but the Anchor Center in Denver, they go right into the NICU, and they do this screening on all children that give consent. It's a really quick screening. I kind of put a copy of our score sheet there. It can take 15 minutes or less to do this. We're not able to go into the NICU, which is fine, but we have asked all of the early intervention programs to refer children who have graduated from the NICU who are under 12 months of age. If we can get a referral to go in and just do this screener that will give us an idea if there are red flags for CVI, because it is so commonly missed. And if we can get in early, because of the plasticity of the brain, we are able to provide strategies and do interventions that can help the child to progress. I have almost always seen children progress who have CVI. It's not something that is, and sometimes they stay static, but typically they will make progress. But we just look at things with how the eye looks, if they'll fixate on those little balls, if they follow the Leah paddles. Anyway, it's really an easy thing, and it's something that they get a score of 0 if it's not a problem, or 1 if we think that there might be an atypical response in one eye, and then 2 if it's definitely atypical in both eyes. And then we add that up, and if they get a score of 6 or more, then we would make the referral to early intervention to us. This I think I've already pretty much talked about. Yeah, we can skip that. So CVI is scored based on the Cvi range. Children are either in phase 1, phase 2, or phase 3. Phase 1 is when children are building their visual behaviors, just looking, fixating, tracking. Phase 2 is when they need to integrate that vision with function. So seeing an object and reaching to get it, or reaching at a switch to activate it. And then phase 3 is when we're working on resolving those 10 CVI characteristics. So they're almost not an issue anymore. There's no longer the need for a certain color. There's no longer the need for movement in order for the child to use their vision. Children who are in the upper phase 2 or phase 3 are typically those children who are falling through the cracks. And it's really scary. I have a child right now on my caseload who is in that range, and it would be, she functions very typically. When people hear she has a vision impairment, they don't believe it. She uses a cane, but she can see across the room, she can run and play, but her vision is very inconsistent. That's another thing with CVI. One day she can use her vision very well. The next day, it's like she can't see at all. And that's going to be very challenging in the school setting. And so it's really important to have that diagnosis of CVI before a child turns 3, so that they are, they're not falling through the cracks, and that at that IEP, they can be addressing the CVI and where the child is on the scale. And that's what this one, that's basically what this slide says. So I'm running out of time, but when to refer a child for vision and a vision evaluation is any of the times any of those red flags are there. Just because they're referred doesn't mean that they're going to qualify, but a vision specialist like myself, we could refer the family to an ophthalmologist. We can say if something's pretty typical, or a lot of times after we've gotten the referral, we go in and they're like, oh yeah, they're not doing that anymore. And it's not a big deal. If parents have concerns, I think definitely make a vision referral. I've been to many referrals where the parents just were worried, or they said that both the parents wear glasses and so they're concerned. And even though I can go into that visit pretty much confident that it won't be someone that I need to see, but I can give that support for the family and guide them to the best direction. And one of my favorite referrals is that the child wears glasses, and so they need to refer me. But if a child wears glasses, that means they're being followed by an eye doctor, obviously, and it could most likely just be for refractive errors, so it's being treated. So I would like to have more information about that one. And teacher versus doctor things. Some things are doctor things, like eye turns. The eyes are not always working together. Some things are teacher things, so needing a controlled environment to be able to see things, a dark background, low auditory clutter, like this light box. Maybe this is more of a controlled setup over here for the child to be able to focus. So we can't do much for the doctor things. I can't put a patch on, I can't do those types of things. But if that eye turn or nystagmus or whatever is having an impact on the child using their vision to reach their milestones, then I can come up, we as teachers can come up with strategies that can help the child to be more successful and to learn to use their vision. Okay, questions. I didn't do too bad. I'm going to stop sharing my screen so I can see people. Did I go too fast?
That was great, Denise. I'm still digesting a little bit because that was a lot of great information. And I don't know if I've got my question real well formulated, but I'm also not real good at waiting. So since nobody else is jumping in, I've got a little kiddo, and he's almost a year and a half. He's got a diagnosis of CP, so he had bilateral intraventricular hemorrhages. The family was told by somebody when he was pretty young that he did have CVI. And recently, during an annual review, he's got a PIP vision specialist coming in. So she was going through the records, and his actual diagnosis is delayed visual maturation. And so she had a conversation with one of the ophthalmologists about the difference between those diagnoses. And what was explained to her was that we're not really sure if it's CVI, so we don't really want to give him that diagnosis yet, but we think it's just taking him a little while. Our conversation with the family went towards whatever it is, we're addressing it, we're going to work on it and make as much progress as we can. But do you have any input on the difference between those two diagnoses? Or
That's a great question. So delayed visual maturation is an easy one for ophthalmologists to give, because it's, and not that I'm putting them down as like, you know what, we don't really know what's going on. And especially in early intervention, we need some time to see what's going to come of this child's vision. And so we will see delayed visual maturation typically before we see a diagnosis of cortical visual impairment. The difference is I've seen children with delayed visual maturation who they've received services for a year maybe, and then they really are doing so much better. And it's not that they had all of those CVI characteristics. It's just that they weren't really having their vision, they weren't really reaching those visual milestones in their development. Now that I have had some children who had the delayed visual maturation diagnosis that I don't see those behaviors resolving, or they definitely have those characteristics on the CVI range that are maybe some of them are resolving, so they're doing some things better, but there's some things that, like the visual field, not using their lower visual field is really common. At least in my experience, I've had quite a few children who don't use their lower visual field. And so I just use that as an example. If I look at those behaviors on the range or the CVI scale, I can kind of, like I say, make my own little, not diagnosis, but, and based on experience, okay, the child that I'm talking about was exposed to drugs in utero. There's a lot of check marks that really can fit that diagnosis. It is important for this child that I'm talking about. I sent a letter to the doctor, and I shared the scores that I received on when I did the CVI range with them, and the behaviors that we're seeing, the characteristics that are really standing out. And based on her medical history, would he consider a diagnosis of cortical visual impairment? And he did. Granted, I don't want him to just do that because I said so.
Yeah.
but really to see the things that we're seeing, because they don't see all of those behaviors in a 5-minute office visit. And parents, when they go in, they are just, I could tell them what I want them to ask them, but then they're like, I forgot to ask. Or, I've been there. You're just happy to be there. You get talking, you forget about what questions you have, and you're done. And so that's been helpful for me in those situations. I don't know that I'm really answering your question, but they do look very similar. And I think as the child grows, and it's fine in early intervention, because delayed visual maturation is an automatic qualifier for vision in early intervention here in Utah. So we can still serve the child easily. But as they get to school, that diagnosis, hopefully by the time they turn 3, they're resolving some of those issues that they've had, and we can determine, or the eye doctor can determine, if they definitely have CVI based on things they're learning with their brain development. And, because sometimes we don't know anything when they're 2 months old, and then they have the MRI, and then they have genetic testing, and then we find out this and this. And so all the check marks add up to make it a better CVI diagnosis than when they first went in and nothing's really connecting. So let's just go with delayed visual maturation. Does that help at all?
Yeah, that does. That was a lot of good information. And I think one of the key things there is, you talked about wanting to watch and see how the vision develops, but it's not a wait and see. It's a, let's get in there and work and help these
Right.
things. So it's not well, he's just delayed and we expect him to mature, so we won't do anything about it. So thank you.
Mm-hmm.
Any other questions for Denise? Great information, and I will share all of her stuff out later today, so you guys will get all of that. There are no other questions for Denise, then I am going to turn the time over to Shelby, and she is going to do our case presentation today.
Okay. Whoop. Are you guys seeing the one with the notes? I don't have any notes, but.
We are, but go up to your display settings and flip that around. It usually will work with that.
Down here?
Up at the top, there's one that I'm sure you could do it that way too.
See, we even did this earlier and it worked, so I don't know why.
I know.
Gotta love technology. Yeah, I'm not sure. We'll just do it like this.
Okay.
Okay, hi, my name is Shelby. I am with the Infant Development Program in Minot, North Dakota, and I am presenting on a little girl today. Foster mom and regular early interventionist are on this call, so I'm familiar but not super familiar. So if there's any questions that I don't know the answers to, they might be answering those questions or telling me the answers to give you the answer. Okay, so this little girl is about 29 months old. She lives with her foster mother, 2 foster sisters, and her foster grandmother. Foster mom is an early interventionist also, so she has her background in early childhood special education. This little peanut has global delays caused by non-accidental physical trauma. She had a skull fracture, 2 right rib fractures, retinal hemorrhage, brain bleed, seizure activity, and hearing and vision loss. She attends direct occupational therapy, physical therapy, and speech language pathology services, and also receives early intervention services, including occupational therapy, physical therapy, speech language pathology, and vision. Her main field of vision is the left periphery of her right eye. For hearing, she passed her newborn hearing screening. She did an auditory brainstem response test in February 2022 with normal results. Feeding, she gets her main nutrition from bottles. They are working on purees and stage 2 baby foods and small chunks of regular table foods. She is not yet self-feeding. Gross motor, she has increased muscle tone primarily on the left side. She takes a daily muscle relaxant and receives Botox injections every 3 to 6 months. She has a lack of protective postural responses. They are working on getting a wheelchair. She uses a gait trainer at direct physical therapy and definitely likes to bounce up and down. Fine motor, she has reduced grasping patterns bilaterally. Expressive language, she vocalizes vowels in isolation and consonant vowel combinations. She says hi, she says yeah. She makes the G, the G sound in response to good morning, and she likes to read touch and feel books. Understanding receptive language, she responds appropriately to no and to her nicknames, and she recognizes familiar voices. They are currently working on feeding and vocalizing when spoken to at direct speech therapy. At direct occupational therapy, stretching her left hand and playing with her holding toys. And at direct physical therapy, walking with a gait trainer and transitioning from sitting to standing. Goals and barriers. I just took these goals from her IFSP. Get up on her hands and knees to crawl or scoot. Independent movement in hands, arms, and fingers without thumbs turning in. Verbally communicate with her family by babbling, taking more solids and mashed foods for feeding, and a vision goal, we'll see as much as possible. One of the biggest barriers obviously is that vision. So I guess these are kind of the questions that we had come up with. We're not sure if this is a thing, but if there's a specialist to determine actual visual ability, does this exist? Or are there resources to figure this out? I guess that's kind of one of the biggest things because we're not actually quite sure how much she sees. How to support other developmental areas with that limited vision, and really any other suggestions that anyone's willing to give, because obviously there's a lot going on, but yeah. Sorry, that was a lot of information and I talk fast when I'm nervous.
That's okay. So a few of the questions you want us to answer in our breakout is there a specialist to determine actual visual acuity or resources? How to support other developmental areas with limited vision acuity and other suggestions. So this would be a great time for you guys to ask any of those questions before we go into breakout groups, if you have any. Hey, well then
This is Pat. This is Pat.
Pat.
Sorry, I can't find where to raise my stupid hand. Anyway, so she has a diagnosed visual field defect. I mean, because of her left hemiparesis. So she's using her right visual field. Is that, or is she? Yeah, she's using her right visual field. Come on, vision people.
Ellie, that's a question for you. I'm sorry, I don't know. I don't necessarily.
It is kind of, they have told me from early on, she has in her right eye, she can see some peripheral out of the left side of her right eye. That's really all I have been told in regards to what she can see. She will track some lights. She will track some movement. She likes to hold her right hand in front of her face and will move it and watch it. But other than specific colors, she really doesn't attract to any specific colors, light, dark. It's all kind of the same. So vision wise, that's all I've really been told is she has some right peripheral in that eye.
Yes. So I guess my question is, this is a neurologic attack. I mean, she had her visual field disrupted because she had the head injury. So my question is, does she see a vision specialist for that specific sort of visual field ability?
Yeah, North Dakota School for the Blind does see her.
Okay. Isn't it called heminopsia, whatever? Isn't there a diagnosis for that? Come on, OTs.
Are you talking about homonymous heminopsia?
Okay, hit it again. What is it?
Are you talking about homonymous heminopsia?
Yes.
Well, usually that's going to be in both eyes will have the same thing though. Usually with that, it's not going to just be with one eye, it would be both eyes that would be.
So it would be the left on one and the right.
It would be left, so you would have the left visual field in both eyes or the right visual field in both eyes. It's not usually just the one eye.
Okay.
Yep, and I've been told her left has no vision at all due to the hemorrhage, the scar tissue, and the amount of damage that was done to the optic nerves in the left eye. The right eye has a little bit of optic nerves that will send images back. They're just not exactly sure what it is.
Okay. Thank you.
And then I think, Kate, did you have a question or was it answered?
It was answered. I just was wondering, well, yeah, I just was curious about what vision service she was seeing since there was a note of the peripheral loss. So it sounds like she had some, but it sounds like the North Dakota for School of the Blind are working with her.
Yep.
Okay, well,
One other question. Sorry. So does she does not have any visually directed reach? Is that correct?
No, nope, she will not reach for things directly. No.
Okay, so where is her hand sort of tactile? Sort of, is she here on her chest, or do you hand her stuff?
I can hand her stuff, or if I hold the toy out there and I put her hand to it once so she knows where it's at, then with her right hand, she'll just continually to bang on it. She doesn't have enough control to like hold toys for any length of time. Her left hand really doesn't have much function to it due to the tone of it. But the right hand, she'll reach out and like touch a book. If I've shown her that it has some texture, she will just reach out there until she finds it. Or if she knows a toy is there, she will hit add it to get a noise response, but she doesn't reach for anything visually in front of her.
I have a question. So was she typically developing before her non-accidental physical trauma? Do you know that, or what age that occurred?
Yeah, she was typical developing until right after turning 3 months old.
Okay.
Okay, well, we have put those questions into chat. Bailey added those. So we're going to go ahead and put you in breakout groups. It's going to be really exciting to see what you guys come up with.